Yes, there is a direct flight.
So unassuming, but so experienced. I really appreciated seeing that. So thank you everyone for having me here today. I am honored to be here. I'm an interventional cardiologist at UC Irvine at Dr. Wong's institution. And one of my passions is women's heart disease and specifically coronary function testing. So I'm going to talk about cardiac microvascular disease and the essentials of coronary function testing in the cath lab. Conventionally, we think of heart disease as atherosclerotic disease of the epicardial vessels. Not loud enough. Yeah. I need the big. Okay. Yeah. So conventionally, we think of heart disease as atherosclerotic vessels. Atherosclerotic disease of the epicardial vessels. But there's growing evidence that there is both structural and functional abnormalities involving the whole coronary circulation, including the microvasculature. And in fact, there's a coexistence of atherosclerotic disease with microvascular disease in most people. Historically, everyone's familiar with the plaque formation hypothesis, which is well validated now. But this process starts with the first step being endothelial dysfunction. And endothelial dysfunction is going to come into play as we move along in this presentation. Normally, the coronary circulation is made up of segments, each of which have a different function. First, we would start with the epicardial larger vessels, which are greater than 400 microns. And those lead to the prearterioles and the arterioles. These segments make up the microvasculature, and those feed into the capillaries. The epicardial arteries are generally a conductance vessel, so blood flow just goes through them. They don't add much to the resistance in the coronary circuit. But the microvasculature, the prearterioles and arterioles, contribute to the majority of the resistance in the system. This is where blood flow regulation happens, where most of the decision-making, distribution, regulation of blood flow to the local tissue occurs. And then the exchange actually happens in the capillaries. The epicardial vessels are regulated by shear stress and endothelial function. And we're going to talk about the normal function and of the microvasculature in the upcoming slides. Historically, everyone's familiar with that if you get obstruction in the epicardial vessel with a plaque, that could cause disease and stenosis. But the microvasculature doesn't actually form atheroma. There's no plaque formation in the microvasculature. When the microvasculature becomes disease, it's usually a process of either thickening or a loss of vasodilation. So in the picture on the top of the microvasculature, some of the disease processes are smooth muscle thickening, smooth muscle cell proliferation, perivascular fibrosis, intimal thickening, or it could be a result of impaired vasodilation. And so when these disease processes occur is when we get obstruction in the microvasculature. So we're going to take a step to just review the physiological indices of the coronary circulation. Many in this room are already familiar with these concepts. But one thing I want to point out is that we don't have a direct way to measure microvascular function. We don't have a direct measurement of it. So current measurements are inferred from the other information that we do have. So coronary flow reserve is the flow in the entire coronary circuit at maximum hyperemia. And we generally use coronary flow reserve after we've ruled out obstructive disease in the epicardial vessel. And obstructive disease in the epicardial is either a lesion less than 50% visually, angiographically, or an FFR greater than 0.8. Once we determine that we have a non-obstructive lesion, when we actually get the coronary flow reserve number, then we can infer that any abnormality from the CFR is actually from the microvasculature. And through the data that we can collect from flow in the coronary tree, we can then calculate index of microvascular resistance and also HMR, which are indices. They're calculated numbers. And those give us information of how much microvascular resistance there is. So there's two concepts to assessing the coronary function. One is to evaluate structural abnormality, and the other is to evaluate functional abnormality. When we want to look at structural abnormality, like those problems with the thickened microvasculature or the impaired vasodilation, that requires an invasive method where we have to put a wire down in the coronary artery and measure flow. And that's where the CFR, FFR, IMR information come in. When we want to test for functional abnormalities, such as coronary spasm, microvascular spasm, or endothelial dysfunction, then we do this through vasomotion testing, which involves acetylcholine medication. Acetylcholine is endothelial dependent drug. And in a healthy patient, if you put acetylcholine in their coronaries, the vessel vasodilates. In a sick vessel, it narrows or completely becomes stenotic. So we do that by two methods. One is we either push acetylcholine into the coronary in a large bolus. That might induce coronary vasospasm. And greater than 90% is considered spasm and often referred to as Prince-Metal angina. But we can also put in graded acetylcholine, like low, medium, and high dose of acetylcholine into the coronary vessel. And we could just measure the diameter of the coronary artery. And if it narrows more than 20%, that's an abnormal endothelial function and an abnormal response. And then to take that a step further, if we infuse acetylcholine into the coronary artery and the patient starts saying, ouch, what are you doing? I'm getting chest pain, and we might just see some EKG changes, then that's an indication of microvascular spasm. So we won't see anything on the cath at this point. We'll just have a symptom from the patient and EKG changes. So how do we do this? To do a comprehensive invasive functional evaluation, some of the papers start with doing the CFR first, which is how the setup is on the left, and some of the papers start with doing the quantitative coronary angiography process or endothelial function on the right. So CFR, it's just there's only one wire on the market. It's the Abbott wire. We put it down in the coronary. You just have to have the function of coronary flow reserve. For QCA, most cath labs have the feature where you manually basically draw the diameter of the coronary artery at one particular point, and you do this with low, medium, and high acetylcholine. So here's one example. So this is a patient who came in with atypical chest pain. Her stress test was abnormal in the lateral wall territory. All she had was this medium or moderate lesion in the left circumflex. At this point, I'm pretty sure this is going to be negative by FFR, but we want to test because her stress test was abnormal there. So put a wire in that, the wire that does both FFR and CFR, we put a wire in that circumflex. And what the display shows us is that the FFR, not unexpected, is normal at 0.99, but she has an abnormal coronary flow reserve. I generally use the cutoff of less than 2.3 as abnormal, and hers was very abnormal. It was 1.7. And then the index of microvascular resistance above 25 is abnormal, and hers was 29. So this was a patient with quote-unquote atypical chest pain, would have probably not gotten a stent, been told that her chest pain is due to something else, but we identified that it's due to microvascular disease. The other information I want to just point out for those who aren't familiar is that the way we get coronary flow reserve by the current available method is by thermodilution. So this is the time of temperature change when we inject 3 cc's of normal saline into the coronary. So that wire that I showed earlier picks up the temperature change from the time of injection to the distal end. So the most important part of all this is finding the patient. This is not the patient that comes in typically of, I have chest pain when I walk. While there are patients with effort angina, a lot of these patients that I see are, I just get this chest pain when I'm resting. Sometimes it feels like a twinge. They say twinge, but I've been getting it for years. Or they say, I get this chest pain, I feel a severe fatigue afterwards. It just sounds like angina, but not necessarily with exertion. So the most important thing is having a high suspicion that they may have angina from non-obstructive blockage. So the way we have categorized this, that if it's angina from non-obstructive blockage, then we call it ANOCA. If you see ischemia with non-obstructive blockage, we call it ENOCA. And if there's actually myocardial infarction, like troponin elevation, then it's called MINOCA. And it's probably a good time to mention that the recent chest pain guidelines said to use the term probably cardiac when talking about atypical chest pain, because atypical chest pain downplays the importance of the cardiac symptoms. So generally, we want to call them probably cardiac chest pain if you suspect it. There is even a study group called the Covatus Study Group who created a criteria for the diagnosis of microvascular angina. They said the definition is there needs to be symptoms suggestive of ischemia or angina, some documentation of ischemia, let's say an abnormal stress test. You prove that there's no obstructive lesion, and then you need to get either an abnormal CFR or a positive acetylcholine test, which is an indicator of that endothelial dysfunction. The one thing to point out is many people, when they see slow flow in the coronary arteries, when they do a cardiac catheterization, think that perhaps this is an indication of endothelial dysfunction or microvascular disease. However, there are several papers that suggest that there's no correlation between visual slow flow and microvascular disease. So here's another patient. She's only 26-year-old female. She's already had 3 episodes of chest pain in the last 6 months, some of which have woken up in her sleep. They're unrelated to exercise. She already went to another ER and her troponin was negative and her EKG was normal and she was sent home. She went to an outside hospital. They did a cardiac cath and said she had a 60% lesion in the proximal right coronary artery. Fortunately for her, the cardiologist did not stent this lesion, but they suggested medical management. But she kept having chest pain, so she saw one of my colleagues, and the colleague referred her to the cath lab to actually do an FFR of the lesion because she was still having chest pain. This is what the lesion looked like. So I do my cardiac cath via radial, and I usually shoot the right coronary first. And so she has this proximal RCA lesion that is somewhat irregular looking, could be atherosclerotic. They told me there's a 60% blockage. I'm going to come back to this. Then I shoot the left coronary artery, and I noticed that at the there's diffuse narrowing between the mid to distal LAD and also the circumflex. Just looks particularly narrowed for somebody of her anatomy. So I gave a coronary nitroglycerin, and her LAD and left circumflex plumped up, and I thought, oh, okay, that looks much more normal. Let me go back to the left side and give intracoronary nitroglycerin as well. But even before giving that, her coronary artery had resolved. Her lesion had resolved and had been responsive to nitroglycerin. So all along, this patient never had a lesion. We stopped her beta blocker. We stopped some of the other, we stopped her aspirin, and we treated her with vasodilators. If anybody's interested to learn more about spasm, the Japanese have a high predominance of spasm in their population, so they've recently updated their guidelines for the diagnosis and treatment of vasospastic angina. So going to the diagnosis, coronary angiogram has low diagnostic yield. In a population of 400 patients that underwent a cardiac cath, only 40% had obstructive coronary artery disease, and 40% had no lesions at all reported. And in one study, in multiple studies, there's been demonstration that about 30 to 50% of these patients with non-obstructive heart artery blockages actually have microvascular disease. So up to 50% in some studies, even after they've ruled out overt vasospasm. Once you've ruled out obstructive heart disease, there are non-invasive diagnostic tests that can assess perfusion, which we're going to get to on the next lecture, fortunately. And that's going to be involving either by PET or cardiac MR. And there are diagnostic criteria for that. But right now, the invasive testing is the reference and gold standard. So whenever we do want to determine if there's microvascular disease, we go to the cath lab. This is one of my fellows demonstrating how we do thermodilution, which is basically injecting that 3 cc via stopcock into the guide catheter for each thermodilution. Clearly, he's taking pictures and smiling while I'm working. And so again, we're going to look for two things. We're going to look for function of the heart by quantifying flow and using a thermodilution method. There used to be a way to put a wire that was a Doppler wire down the coronary artery and actually directly measure flow with velocity. But that wire is no longer available. They're updating it, but it was also $1,000 per wire, so not very practical. And then we can assess for structural abnormality looking at the qualitative assessment of the coronary artery after acetylcholine. So two drugs that you need to do coronary function testing. Adenosine to get maximum hyperemia. And you can do intracoronary adenosine. We tend to do IV adenosine infusion. And once you see hyperemia develop, which is the blood pressure drops, we start doing the thermodilution test, and you need to get 3 of them. So that's why we start doing them early, because we don't want the patient to go into heart block while we're doing that. And then once we're done with that, we move on to the acetylcholine perfusion. And at that point, we assess for, we do the 3 doses of acetylcholine and then measure afterwards the narrowing, and also see if the patient has any angina during the infusion. And if anyone's interested in the acetylcholine dosing, that's been published in the Stiletto paper. So it's important to tell the patient to not take any nitroglycerin, long-acting nitroglycerin 24 hours before the procedure, and also to hold any long-acting calcium channel blockers 24 to 48 hours before. Avoid caffeine, because all these can interfere with your adenosine or your acetylcholine testing. And everybody has a role. It's very orchestrated when we do this study. And once you have it down, what everybody does, it becomes very fast, even though it seems like it's very long and tedious. For example, I think again, it's very important to know if you're going to anticipate a problem like this in your patient, because if you give a radial artery cocktail for radial access, which I usually give nitroglycerin, if I'm anticipating that the patient's going to need microvascular testing or may have vasospasm, I skip that nitro part. So it's important to anticipate. But so once we do our testing, we have a variety of cutoffs, and I've gone through them as listed on the right there, different parameters for cutoffs, and I've gone through them already, so we'll skip through that. So here's another case. 55-year-old female, no cardiovascular risk factors, acute onset of chest pain after she was having an emotional and exciting call on FaceTime. So just her FaceTime call got her a troponin, high sensitive troponin of 1200 and then 1800. She nearly had the same exact symptoms 2 years ago and went to an outside hospital. Her echo was normal. She had wall motion abnormality, and her cath was reported with no disease. So in this case, we did the coronary angiography, and again, she didn't really have any obstructive lesion. The distal vessel has some disease, but it's small vessel disease, and thought that it's probably not contributing to that level of troponin. So that's the wire that we use, the pressure wire. It's supposed to be placed down at the last 1/3 of the coronary artery to get closer to the microvasculature, essentially. And we got some information here. So this patient also had a CFR of 1.8, well below 2.3, and an index of microvascular resistance of 53, much higher than 25, which is the cutoff. So again, another patient with multiple hospitalizations, quote unquote atypical chest pain, who clearly has a reason for her angina. So this patient, because she had an elevated troponin, is considered Minoga. So why do we do all this? Because when you identify what category these patients go into, then you could treat them directly for that cause. So the importance of this, a lot of these are women, so they don't have high blood pressure. They can't really tolerate nitro or diltiazem or anything like that. So if you can put them in a category and give direct measurement, then they'll do better. So it's important to recognize that people with coronary microvascular disease do have a higher rate of MACE. It's not a benign disease. The arrows there are pointing to patients with chest pain, but no obstructive lesions on cardiac cath. And they compare to the blue line, which is no chest pain. So there is a mortality associated with it. And even patients with low CFR have high mortality as well compared to normal CFR. And the lower it is, the worse it is. The European guidelines said guide wire-based assessment for microvascular was a 2A in 2019. As of 2024, it's a 1B recommendation. It's been upgraded to do wire-based assessment of angina with non-obstructive disease. This costs money. These patients go to the hospital multiple times, multiple procedures, and you could see they're not that far in cost compared to someone who has 1 vessel, 2 vessel, or 3 vessel disease. What's the treatment? It's all the good stuff that we give for regular cardiovascular prevention, plus some directed treatment. There's a whole host of medications, and some that are not yet proven are Rho kinase inhibitors, which seem very promising in the future. And currently, stem cells are being tested, and a device which is a coronary sinus occluder. And this is a great paper that I'll reference in the future, which is once you decide what kind of endotype that they have, you can direct their therapy to that disease process. And it's not to overwhelm, but to show that these medications do have side effects, so directing it to the right patient is important. And if you ever have any questions, these are recent documents that are very comprehensive. Lastly, going to end here with a case, 62-year-old female with routine follow-up in the preventive cardiology clinic. She, in passing, on the way out, says, you know, I've been feeling this little chest pain, and sometimes I get short of breath at night. And she does have a history of hyperlipidemia. She's on PCSK9 inhibitors. She didn't want to be on a statin because she said her mother had dementia, and this is not true, but she just didn't want to, she wanted to avoid getting dementia. She also had a surgery for endometrial polyps coming up soon, so a bleeding issue. She had two brothers who had heart attacks. She had a calcium score which was 0 a couple of years ago. She went on the treadmill and exercised 7 minutes, but the echo showed some non-specific wall motion abnormalities in the apex. She was sent for the cardiac cath with the intention to do coronary function testing. It happens that her cardiologist anticipated microvascular dysfunction and ordered the procedure that way. So we took the first picture, coronary artery, maybe some mild diffuse disease in the right coronary artery. Again, because I thought I was going to do coronary function testing, I didn't give any nitroglycerin. And then when we shot the left coronary artery, there's this awful looking osteal LAD lesion, which was very surprising. But one thing that caught my eye was the fact that the rest of her vessels looked fine. She doesn't have disease everywhere. So in this moment, I'm planning my procedure. I said, oh gosh, it's osteal. I'm going to have to do this and that. And then I thought, let me give some nitroglycerin. And the lesion improved significantly. And so it still looked a little hazy. So I thought, you know, I should probably find out what's going on.
Yes.
So I put a wire, and it showed soft plaque. It still was physiologically not significant because her area is definitely greater than 4. It was 6.9. But there was definitely presence of non-obstructive soft plaque. And so after that, we did the coronary function testing. It was normal. And we diagnosed her with ANOCA, treated her for vasospasm, and she went home. Still doing fine. Thank you.
Thank you very much for a great lecture. Really, there is a lot of questions and a lot of issues because we are doing for more than 20 years all these functional techniques. So we can discuss later. Now I don't think that we have enough time. But just one thing I want to emphasize, which is really very important, is to give nitroglycerin. So sometimes we are very fast, then we see stenosis. This is a French school, interventional school. They are giving all the time nitroglycerin, but this is, you demonstrated two very nice cases with the nitroglycerin and the vasodilation, and plus the IVUS, which is also very important for this patient. So thank you very much. Maybe there is one, huh? Yeah, Vlada with
Thank you, Alien, for the beautiful presentation. I have one question about my first patient. This is perfusional scintigraphy of myocardium. 20 years ago, I performed perfusion scintigraphy, and we know that perfusion scintigraphy had a big percent of false positive patients.
Okay, yeah.
This patient had health epicardial artery. Probably solution for this false positive patient is not false positive. Probably the patient had a microvascular disease. Your opinion about it?
Yes, I 100% agree. I think there's two entities with especially nuclear stress tests. One is, are those really false positives? If they have true angina symptoms, I think they could very well be microvascular dysfunction. And there's sometimes patients who have a lot of chest pain with the adenosine part. I think that population of patients probably have some level of microvascular or some spectrum, those ones. And then there's this interesting entity that I didn't even talk about, but it's increased nociception. It's this group of people who just have a hypersensitive pain pathway, and so they may need to be treated with chronic pain meds like tricyclics. So it's a little different than the actual positive stress test, but we do recognize them now.